Okay. All right. So we began, or I started with the general overview of endocrine system, and then um, I'm sure we all know that the endocrine system consists of glands. Okay, and then these glands produces hormone. Right. These glands produces hormone, and then the hormones, each of them have their specific function. Okay, each of them have their specific function in the body. So we have a lot of glands. We have the thyroid gland, we have the pituitary gland, we have the parathyroid gland, okay, we have the islet of the pancreas, we have the adrenal gland. Okay, so we have several glands in the body, and then they all produce their hormones for specific functions in the body. Okay, so we started with the pituitary gland. Okay, so we didn't focus on, or our focus is not on any other gland. Okay, we are just focusing on the enclave's interest. Okay, we are focusing on what the enclave would demand when it comes to the gland. That is what our focus is on. So we started with the pituitary gland, whereby under the pituitary gland we spoke about the DI and then SIADH. That is diabetes insipidus, and then syndrome of inappropriate antidiuretic hormone. Okay, syndrome of inappropriate antidiuretic hormone. Very good. Syndrome of inappropriate antidiuretic. So we realize that in DI, right? In DI, there is underproduction of the antidiuretic hormone. Okay, the antidiuretic hormone is secreted primarily to help control fluid. Okay, very good. So when the pituitary gland produces the antidiuretic hormone, it helps to regulate fluid balance and then electrolytes, especially sodium. Okay, so the pituitary, the antidiuretic hormone acts on the kidney to reabsorb fluid so that there will be no, or there will be, a well balance or maintenance of fluid in your body. But then in DI, there is what? There is underproduction of this hormone. Thereby, or therefore, the hormone is not enough to regulate the fluid. So the patient just pass or just bring out fluid. Okay, the patient just brings out fluid. You get it? So one thing you should know, I think when I was explaining, I gave an example, okay, or let's say a scenario, an analogy. So I use this as an example. Imagine you are going for a party, okay? Imagine you are going for a party, and then at the gate to the entrance of where they are organizing the party, there was a bouncer, right? Then this bouncer is supposed to check those who are will be allowed in and those who will be allowed in. Okay. So imagine the bouncer as the ADH, the antidiuretic hormone. Just imagine the bouncer as the antidiuretic hormone. Okay. And then the place they are doing, the place they are having the program is where your body and then your kidneys and any and everything. Okay. Very good. So because you imagine the situation, you went for the program, and then we didn't have a ticket for the program, okay, but then there was no bouncer. You can go there freely without any hesitations, right? You can just go inside really without any hesitations. So in the same way, when the ADH is not enough, it doesn't hold water. So water comes out freely. Okay. There's no bouncer to check how water is coming out and how water is being maintained. So it just comes out free. That is the function of the ADH. Okay. It acts like a bouncer on the kidney. Hey, don't bring too much water. So let's put some. Don't bring. So when the ADH is not enough, there is no bouncer to prevent or to check the balance. So the water just comes out. Okay, the water just comes out. So that is what we see in the eye. Okay, so there is excess fluid coming out. So there's polyuria, and because we are urinating plenty, there's going to be polydipsia. Okay, polyuria, polydipsia. You can be dehydrated because you are bringing more water. It can be dehydrated. You can have or show signs of dehydration. Okay, it can be weak pulse, and then because of that, you are even going to go into hypotension because there's going to be hypovolemia. And this will bring a corresponding symptom of tachycardia because the body will try to compensate. Okay. So these are some of the signs and symptoms of what? Of DI. The major diagnostic investigations, we are looking at what? Urine specific gravity. We are looking at what? The serum osmolality and then the urine osmolality. Okay. So to ask, who can remind us the normal value for urine specific gravity?
10,
One
10, 10, 30.
30. Yes, please, let's break it down. Let's put the 10, 10, 10, 30 down. Let's break it down.
1.0102 to 1.030.
Very good. And then in DI, what are you expecting to be the value? Or where should we expect the value to be in DI, the unit specific gravity? Where?
Decrease.
Decrease.
It will decrease.
Okay. So anytime you're urinating plenty, so just have this at the back of your mind. Okay. Anytime you're urinating plenty, your specific gravity goes down. Okay. You're urinating plenty, your specific gravity goes down. And anytime you're not urinating plenty, it goes up. Okay. So there's going to be a low urine specific gravity. That is, it's going to come below 1.010. And then what happens to the serum osmolality and the urine osmolality? Who can remind us?
It will increase.
Which one will increase?
When you are losing water, the serum OS will increase.
The serum osmolality will increase.
Yes.
And then that of the urine will decrease, right? Yes. So that is it.
Yes.
Yeah. So that is it. Okay. So I remember also making this scenario analogy. Okay. So just pick a thick red paint. Okay. Just imagine a thick red paint. A thick red paint. Okay. And then you add more water to the paint. Just add more water. Just add more water. You realize at the point in time, the thickness or the deep color of the red will begin to fade out. Okay. And will begin to fade out. So that is what occurs in SIADH. Meaning that in the opposite, that is the DI, when there's no water, you're going to see the thickness. Okay. So because the patient is bringing out just urine, just water, you are just urinating. You are just urinating. There's no ADH. There's no antidiuretic hormone. Okay. To stop diuresis. There's nothing like anti-diuresis over there. The hormone is not there. So you are just bringing out water. There's diuresis. There's excess diuresis. You are just bringing out water. Because you are just bringing out excess water, the thickness of your blood become more. Okay. There's no water to dilute your blood. You get it? There's no water to dilute your blood. This will make your blood very, very thick. So there's going to be a high serum osmolality. But then, because you are bringing all out water, there is no there is no retention of urine. There's no urine being stuck anywhere. You are just bringing it out. The serum osmolality, the urine osmolality, or the concentration of your urine is going to what? It's going to go down. Okay. So in the management, you must replace fluid. You must give desmopressin. Okay. So we give desmopressin to act on the kidney very well to help reabsorb water. Okay. We give desmopressin, vasopressin, replace fluid. You correct or the dehydration. You prevent or you make sure that there's no what hypovolemic shock. So that goes into the management for what? For DI. Then we went on and treat SIADH. SIADH, let me say that if not the exact opposite, it's about 90% opposite of what? Of DI. Whereby here, imagine the same analogy I gave. Okay, here, when you went to the party, in fact, there were thousands of bouncers. So because you don't have tickets, you are not going to be allowed in. Okay, so here, the ADH is produced in excess. Okay, there are a lot of bouncers, there are a lot of ADH, or it's in excess. So it's not allowing anybody enter. So it's in the same case, because the ADH is in excess, it's not allowing water come out at all. Okay, it's not allowing water to come out at all. So that is something that you do. So here there is weight gain. Patients start having weight gain. There can be pulmonary edema because fluid start to shift into the lungs. Okay, there can be pulmonary edema. There is weight gain. Okay, there is puffiness around the eyes. Okay, there can be hypertension. Okay, because there's increase in intravascular fluid volume. All this occurs in what? In SIADH. Okay, very good. In SIADH, the laboratory investigations, we are seeing the opposite of that of EI. Okay, we are seeing that of the EI. So here there's going to be a reduction in an increase in specific gravity, but the serum and the urine osmolalities, because there's too much water diluting your blood, the serum concentration will go down. Okay, so there's decrease in serum osmolality. and then an increase in what? In urine osmolality. Okay. Then here to restrict fluid, you check electrolytes very, very well. Okay, so because in this condition, there's going to be hyponatremia. Okay, you give sodium rich diet and all those stuff. That was what we did with regards to SIADH. And then yeah, I think the recordings are in the page, right? So those who are not here when we treated the conditions can kindly check from the page, okay, and make sure we all watch the recording so that we can refresh ourselves or get the understanding of some of the conditions. Okay, very good. Then we went on and treat when we went on to treat hyperthyroidism and hypothyroidism, then Addison disease and Cushing's syndrome. Okay, so in hyperthyroidism, there's excess production of what? Of thyroid hormone. Everything is going up. There's hypertension, there's tachycardia, there's hyperthermia, there's heat intolerance. Okay, there's everything is trying to go up. There's diarrhea in what? In hyperthyroidism, but in the hypo, everything is also going down. Okay, in the hyperthyroidism, what do we give? We give propyl to uracil, right, and the methimazole. Okay, we give propyl to uracil and the methimazole as the drugs we give to treat or manage the condition. And in this drug, you should know that anytime you start giving them, it reduces what? Your white blood cell count. So anytime you start these medications, you have to make sure that the patient is being checked properly to prevent any sign of infection or to prevent any infection. Okay, very good. Then the rest of the management comes in. Then in hypothyroidism too, we give what? Levothyroxine, right? So I remember I gave an acronym, level. I remember I gave an acronym, level. Who can remind us what goes into the level? Hello, who can remind us what goes into the level?
I can remember the first two.
Okay.
The L stands for you're taking it for life. And E stands for you take it early in the morning.
Okay. And the V. Who can
And then,
remind us in the last two? Yes.
yeah, all baby safe or something.
Yeah.
Thank you.
Yeah. So the V, who can remind us on the V? Madam Sandra, yes. Madam Sarah, sorry, Sarah.
Yeah, then I think there is agitations and then irritations.
Very good. So the level,
Very hyper.
very good, very high pay. Very good. So that goes into anytime the NCLEX want to test you around level thyroid, most of the questions is around this level. Okay. Most of the questions are around this level. I keep on saying, okay, especially in discussion, that when you are studying for pharmacology, okay, drugs, there are things that you should take into. You shouldn't have bother yourself with too much of the things. Okay. So when you are studying pharmacology and the drugs, the NCLEX, they are interested in one. The time the drug is being taken, okay, usually the time the drug is being taken, whether it's in the morning, in the evening, or wherever, okay, when the drug is being taken, they are really, really interested in that, right? When the drug is being taken. Then two, the side effects of the drugs, okay, the side effects of the drugs. Then lastly, the contraindications to the drugs, okay, the contraindications to the drug. These three usually NCLEX test. These are the areas usually NCLEX focus when it comes to pharmacology. For mechanism of action, it's not that plenty. Okay, mechanism of action, you don't really see that much. Okay, but when a drug is being taken, the contraindications and then the side effects, at least you should know when it comes to the major drug that the NCLEX will make. Okay, so in levothyroxine, remember the acronym level, LEVO. L stands for lifelong. Okay, meaning the drug should be taken for lifelong. Okay, the drug should be taken for life or for life. Okay, the drug should be taken for life. Then we have E. E is early in the morning or on an empty stomach. Okay, early in the morning or on an empty stomach. Okay, early in the morning or on an empty stomach for the E. Then V is very hyper, meaning that it takes you up. So it causes tachycardia, can cause like agitations and all those stuff. Then the last O is that the baby is fine. Okay, the baby is fine, meaning that it can be given in pregnancy. It's not contraindicated in pregnancy. Okay, so at least you should know this when it comes to child. Yes, is someone speak? Okay, okay, all right. So that is that for hyperthyroidism and hypo. Then we did Addison's disease and Cushing's syndrome. So we realized that in Addison's disease, there is no production of what? Please, can we all mute down? Please, can we all mute down? Madam Sarah. Okay. So we realized that in Addison's disease, there's no production of what? Of cortisols, right? There's no production of cortisols. But in Cushing's, there's excess production of the cortisols in Cushing's syndrome, rather. Okay. Then we realized that there is Addisonian crisis. That is the excessive form of what? Of Addison's disease. When you don't treat the condition well, when you stop taking the steroids abruptly, there is what? There is Addisonian crisis, right? And then you have to give the steroids IV to correct the situation. Okay. Then you realize that in Cushing's syndrome, there's excess production of the steroids. There can be bleeding. There can be hyperglycemia because cortisols contribute to what? Glucogenesis. That is excess breakdown of glucose. Okay. There can be osteoporosis as well. So we establish all those facts in Addison's and what? Cushing's syndrome. So please, once again, let's try and then refer to the recordings on the page. I think Gia shared it on the page so that we can just update ourselves on some of these conditions. Okay. Very, very. All right. So we are resuming, or we are zooming on to today's discussions. Okay. But then I want to ask a question under the Addison's and Cushing's syndrome. Okay. Someone should help me. Okay. If you are able to talk about the Addison's, or if you're able to explain it in Addison's, it's the same thing in the opposite is in the Cushing's syndrome, right? Very good. So in Addison's disease, there's an imbalance of sodium and potassium. In Addison's disease, there's an imbalance. It is the same in Cushing's syndrome. Cushing's syndrome too. There's an imbalance of sodium and potassium. Who can help us with regards to Addison's? What occurs in Addison's? And then what generates the imbalance between the sodium and the potassium in Addison's? Anyone to help us? Mary, please, sorry, I can only mention the Mary. Okay, I can see your hand up. Can you help us, Madam Mary?
Thank you very much. With the Addison, the potassium is high. Potassium is high, calcium is high. Then we have a what is it? Sodium being low with glucose being low. But if you go to the Cushing syndrome, potassium is low in that regard, and the calcium too is low. Whilst that of the glucose and that of the sodium is high. That's why we have hypertension and the other district. Thank you.
So thank you so much. I asked that what occurs, especially with respect to the sodium and potassium. Okay, with respect to the sodium and potassium, what occurs for there to be an imbalance between these two electrolytes? Anybody to help us? Oh, hello, class.
The question again.
Okay, my question is that in Addison's disease, okay, so in Addison's disease, there is low sodium and high potassium. What contributes to this imbalance?
Hello.
I think
Hello.
Yeah, I'm listening, Madam. I am.
So in Addison's disease, there's low sodium and high potassium because the patient is voiding, therefore losing potassium through the urine. And then once potassium is lost sodium will go up. That's
Okay.
what I can say about it.
All right. Thank you. Yes, Madam Juliet. Madam Juliet, you wanted to speak?
Hello?
Yes. Madam Juliet, or is anybody else wanted to speak?
Okay, let me try. Yeah.
Okay.
So with so the imbalance is due to the fact that there is normally with normal aldosterone production, aldosterone holds sodium and then excretes potassium. But in this case, when there is low production of aldosterone, that leads to excretion of sodium, and then that will cause low sodium, and then potassium will be retained, and that will lead to the high potassium.
Yes. Very good. Very good. Okay. Very good. So that is what I was actually looking for. Okay. So in Addison's disease, what occurs? There is low adrenal hormones. Okay. So there is low aldosterone, low cortisol. And then as Madam Marianne said, okay, aldosterone actually, when they are produced normally, like you and I not suffering from any addiction, meaning we have normal aldosterone levels. Okay. So the aldesterones, they are being produced to retain sodium. Please, let's take note. They are produced to retain sodium and then excrete potassium. That is their normal function. Okay. I mean, the normal function of the aldosterone. Okay. They are produced to retain sodium and excrete potassium. But then in Addison's disease, these aldosterone levels are low. Okay, they are low. So that function to retain sodium is not there. And that function to excrete potassium is also not there. Therefore, sodium begins to leak out, causing or leading to what? Hyponatremia. Because now the function of the aldosterone to hold the sodium is no longer there because the aldosterone is not produced enough. So there's going to be a leak out of sodium leading to hyponatremia. And then instead of excreting the potassium rather, because the aldosterone once again their hormone the levels is low, they can't do what? Excrete the potassium. Okay, they can't excrete the potassium. Therefore, the potassium will rather be retained, leading to what? Hyperkalemia. This is the opposite in Cushing syndrome. Okay, the same idea in Cushing syndrome, but then the opposite way. Okay, the opposite way. So I think that's one of that. So because of that, in other sense, and in both Addison's and Cushing, you have to really pay attention to ECGs. Okay, you have to focus on the patient cardiac monitoring, focus on ECGs very, very well, because in hyperkalemia, there's going to be what? ECGs reading. Okay, in hypo, there's going to be ECG. So in hyper, we are expecting an ST elevation, a peak D wave. Okay, then in hypokalemia, we are expecting an ST depression and then a U wave. Okay, very good. So these are some of the characteristics. Then we have to expect or you observe the patient keenly or closely for what? Cardiac arrhythmias. Anytime there is alterations in potassium level, what comes to our mind first is what? Is cardiac arrhythmias. So we quickly put the patient on a cardiac monitor. Then we start monitoring the patient ECG. Very, very critical. Okay, so that it doesn't lead to any complications. So that is that. So those are the topics we've treated so far. I think we are left with some few others, and then maybe we will end on the endocrine system. Okay, so we were able to treat DISIDH, hyperthyroidism, hypothyroidism, Cushing syndrome, and so today we are beginning with hyperparathyroidism. Okay, hyperparathyroidism, hyperparathyroidism. Okay, hyperparathyroidism. So this, I'm about to ask a question. It is not on my slide. Okay, so I want to ask that question. Who can help us locate where the parathyroid hormones, parathyroid glands are? Who can help us? Where the parathyroid glands are? Anybody to help us? Where they are located? Madam Sylvia Kwashi, yes.
Yes,
They are
please.
located glands.
They are located behind the thyroid gland.
Very good. Behind the thyroid gland. Let me try and see if I can show a picture of it. So that we see. They are four, usually they are four in number, okay. They are four in number. They are four in number, and they're located behind the thyroid gland. They are four in number, but I think this picture will help. This can you all see? Can you see my screen?
Yeah.
Hello.
Yes, you can see.
Thank
Yes,
you.
we can.
So we've all seen the parathyroid glands, right? This is how it looks like, and they are behind the thyroid gland. Okay, they are behind the thyroid gland. They are four in number. So this is how it is. So we can now conclude, okay, or we can now remind ourselves once again why thyroidectomy can contribute towards hypothyroidism. Okay, because if there is excess production of the thyroid gland, that is the hyperthyroidism, and then the patient is scheduled for what? Thyroidectomy, and then you remove the thyroid gland. Okay, mistakenly you can take off the parathyroid gland because they are just at the back of it, right? And this can contribute to what? Hypoparathyroidism, because the glands, when they're taken out, they can't produce what? Enough, or they can't produce the thyroid hormones again, or the parathyroid hormones again. Okay, so that is that for the location of the parathyroid gland. Okay. Just behind the thyroid gland. Okay. Okay. So hyperparathyroidism, okay, is a condition where one or more of the four parathyroid glands becomes overreactive, producing excess parathyroid hormone, leading to hypercalcemia or elevated calcium level. Okay, so let's take note. Okay, the parathyroid glands, they are four in number. They are located behind where? The thyroid gland. And then the function of this parathyroid gland primarily is to regulate calcium and phosphorus levels. Okay, is to regulate calcium and then phosphorus levels. That is the basic function of this parathyroid gland. They are being produced, the gland, they produce the parathyroid hormone. Okay, so when they produce the parathyroid hormone, they help to regulate calcium levels in the blood. Okay, so basically, that is all about the parathyroid gland and their hormone. They are being produced to regulate calcium and phosphorus levels, okay, in the blood. Now, in hyperparathyroidism, we see that what the gland is being overreactive, so it is producing excess of the parathyroid hormone, and then because this gland secretes the calcium, okay, these hormones secrete the calcium, and then they are now producing excess. There's going to be what? High calcium levels or elevated calcium levels, which we call what? Hypercalcemia. Okay, which we call hypercalcemia. So let us remind ourselves again. You know, one thing about this endocrine system that makes it easy for us is that the conditions are opposite one. They are opposite of each other. Okay, and anytime we hear the hyper of the condition, it simply means that the hormone is produced in excess. Anytime we hear the hypo of the condition, it means that the hormone is produced in what? In inadequacy. Okay, so I think this will help us. With regards to the foundation of our understanding of our endocrine systems. Okay, they just consist of glands, and each of the conditions you have the hyper and then the hypo. Okay, in the hyper, there's excess production of the hormone. In the hypo, there's no production of the hormone. And then usually they are just opposite of each other. Okay, they are just opposite of each other. So in hyperparathyroidism, once again, we say there's an overreaction of what? Of the four parathyroid glands. Okay, and then this produces excess of the parathyroid hormone, leading to hypercalcemia. So we have types of the condition, or the types of hyperparathyroidism. We have the primary, the secondary, the tertiary, and then the family history type, or the genetic type. So the primary hyperparathyroidism is the most common form and usually caused by a single parathyroid gland adenoma. That is when there's a cancer of the parathyroid gland. Okay, so when there are cancer, anytime we hear cancer, what comes to mind? Proliferation of cells. Okay, cells begin to grow abnormally. Okay, so already there is this parathyroid gland with cells producing parathyroid hormone. So if there's a cancer, okay, if there's a cancer, there's going to be excess production of what? Of the cells. And then this excess production of the cells can mimic the normal cells. And then they also begin to produce more of the parathyroid hormone. And this is how we get primary hyperparathyroidism. Okay. This is how we get primary hyperparathyroidism. Okay. So when there's a cancer of the parathyroid gland, it can cause hyperthyroidism. That is the primary one. And secondary typically occurs in patients with chronic kidney disease, vitamin D deficiency, or calcium malabsorption. So let me try and then explain this one a bit, okay? Or let me try and then expand it a bit. So when you have a chronic kidney disease, okay, when you have a chronic kidney disease, and then once again, let me say this, the primary and secondary, anytime you hear primary, it means that the situation is in the gland itself, okay? It simply means that the situation is in the gland itself. But when they talk about secondary, I mean, it's usually outside the gland, okay? So we have the kidney disease, vitamin D deficiency, and then calcium malabsorption. So in chronic kidney disease, the patient does not have the ability to excrete certain substances. The patient does not have the ability to excrete the certain electrolytes because the kidney is not functioning. The basic function of the kidney is to excrete. Okay. So if the kidney is being diseased, meaning that function of excretion is no longer there. Right. So the kidney can no longer take away calcium. So anytime we take in calcium, they just build up in the body. Okay. They just build up in the body. The body can no longer bring the calcium out, and that can contribute to what? Hyperparathyroidism. Okay, then we have vitamin D deficiency. We all know that if calcium will be absorbed properly in the body, okay, if calcium will be absorbed properly in the body, usually they have to add what? Vitamin D supplement or vitamin D rich food. Okay, so vitamin D aids in what? Calcium absorption. Okay, vitamin D helps in calcium absorption. So when there is vitamin D deficiency, okay, it means that calcium will not be well absorbed. Okay, anytime there's vitamin D deficiency, the calcium will not be well absorbed, and then this will do what? This will cause the parathyroid gland to overreact. So, the body is supposed to produce what do you call it? Parathyroid glands, parathyroid hormones. Now, the body lacks vitamin D, and therefore there's what? There's calcium malabsorption. So even if the glands tries to produce it, the calcium is not being well absorbed. Even if you eat calcium-rich food, they are not being absorbed because there's lack of vitamin D. Okay. So now the body will be like, hey, my calcium level is down. My calcium level is down. Anytime I eat calcium, they are not being absorbed. I have no vitamin D. So the brain will just begin to stimulate. Now let's compensate. Let's compensate. Let's push the parathyroid gland to produce more calcium. Let's push it. Let's push it. So when they begin to stimulate, please let's do it out. Madam Linda. Okay. So anytime they are low, okay, the body begins to compensate by stimulating the parathyroid gland to produce more calcium, thereby leading to what? Leading to hyperparathyroidism. Okay, very good. So that is for the vitamin D deficiency and the calcium malabsorption. Please, are we okay? Are we getting the understanding, please?
Yes.
Okay, all right. Then you have the third one, the tertiary hyperparathyroidism. That one develops from prolonged secondary hyperparathyroidism. That is, if the kidneys are not being treated, if the vitamin D deficiency stays for long, okay, or if there's calcium malabsorption for long, then we can have what tertiary hyperparathyroidism. Then we have the fourth one, that's the familial hyperparathyroidism. That is rare genetic disorders. Okay, it is a bit rare with regards to the familial hyperparathyroidism. That is through genetics. Okay, maybe from mother to child, from sibling to the other sibling, and that and do stuff. But then this one is a bit rare. It's a bit rare. All right. Let's look at the causes. Yeah.
Please, I just want to clarify something with what you said.
Okay.
That you said the vitamin E helps calcium to be absorbed, right?
Yeah.
And so if the calcium or somebody eats calcium and then it's not being absorbed, that is when the parathyroid glands are being stimulated to produce more calcium.
Very good.
Is
Yes.
that it?
Yes. Very good.
Okay. All right. Thank you.
Very good. So
Boss, please, can you go back one? I want to check something.
okay.
Okay, thank you very much.
Okay. All right. You're welcome. So that is the same idea. Okay. I think I have been saying this a lot. Okay, all the time, that our body, the way God created us, God created us in such a way that anytime there's something wrong in our body, there must be a compensating mechanism. Even before we go to hospital, to help us. Okay, that is how God created the body. God created us naturally in such that when there's something wrong, actually, the brain must help compensate in some way or somehow. Okay, before there will be treatment. Okay, so anytime there is low calcium, we are not taking any more calcium rich foods. Okay, we are not taking any more vitamin D rich food. Right. Anytime they are low, the brain will stimulate what the parathyroid hormone that hey, they are low calcium. Can't you see? There is no vitamin D, so there is no calcium. The guy is not taking a lot of calcium. Can't you see? So the person is running low on calcium. Please produce more calcium. And this will stimulate what the parathyroid gland secretes more of the parathyroid hormone in attempt to correct the hypocalcemia. And this will cause what? Or this will lead to what? The hyperparathyroidism. Right. I'm sure we are okay. All right. So let's talk about the question. The question, I think I even said some under the definitions, right? I think I said some under the types rather. So we have the adenoma I said about the cancer. Okay. Then we have parathyroid gland hyperplasia. When we say hyperplasia, what does it mean? Hyperplasia. Or let me see, what is the difference between hyperplasia and hypertrophy?
Hello, sir.
Yes. Yes.
Hypertrophy is increased production size, and
Please, if someone is speaking, let's kindly, Madam, please, Mr. I think Kabiru, kindly meet up, okay, so that Madam Nana can speak, okay. All right, please kindly go on. And come a bit louder.
okay, so sir, I was saying that the hypertrophy is increase in size, and with the hyperplasia is increase in numbers.
Okay.
Numbers.
Okay. All right. So hyperplasia, right, is increase in the number of cells, and hypertrophy is the increase in just the abnormal increase in the size of the organ. Okay. Like size of a particular area is hypertrophy, but then when the cells increase in number, so at first we were getting 5. Now it is going to 10, 15, 20. That is hyperplasia. They just increase in the number. And hypertrophy is when the size just increase. Not necessarily associated with the increase in the number of the cells. Okay, that is the difference. Okay. Now, when the parathyroid gland, the cells in the gland begins to increase in number. Okay, then it can also contribute to what hyperparathyroidism, because it is the cells that will produce the hormone, right? It is the cells that will produce the hormone. So if the cells begins to increase in number, then obviously the hormone will produce in excess. It will also increase. Okay, very good. So that one too is a cause of what? Of hyperparathyroidism. Then you have parathyroid carcinoma. That one too is rare, but then the parathyroid carcinoma is also a cancer. So it has a relation with the adenoma. Okay. The carcinoma and adenoma, they all fall under what? Under the cancerous group, right? So that one too, there is excess production of what? Abnormal cells. And then they mimic the normal cells, leading to production of what? More parathyroid. Then we have the four. We have the familial syndromes, which is example is the multiple endocrine neoplasia. Okay, the multiple endocrine neoplasia. This conditioning, anytime you hear multiple endocrine neoplasia, it is simple. It's simply a situation whereby most of the endocrine glands, okay, most of the endocrine glands are suffering from cancer. It is just like that, okay. Because when you hear neoplasm, the word neoplasia comes from neoplasm. Neoplasm is related to cancer. Okay, very good. So multiple endocrine neoplasia. Anytime you see this, it's simply a situation whereby multiple glands of the endocrine system. So let's say thyroid gland, adrenal gland, pituitary gland. When major or multiple organs under the endocrine glands are being suffering from cancer, we say that one is multiple endocrine neoplasia, and that one can be a cause of what? Thyroid, hyperparathyroidism. Okay. Then five, we have lithium therapy. Okay, so under lithium, one thing you should know is that, okay, on the ankles, usually or anytime we hear lithium, okay, on the ankles, I mean, with regards to the ankles, so we can give lithium any other time, or I mean, in several situations, right? But then I just want to ask, in our ankle study, so far, how far you've come? Anytime you hear lithium, which condition comes into mind?
Bipolar.
Bipolar. Bipolar. Okay. Anytime you hear lithium, at least bipolar should come into your mind because lithium is a mood what? It's a mood stabilizer, even in bipolar disorder. Okay. Very good. So you're on your ward, or you're on the ward, right? You're on the ward with a patient with bipolar disorder, and then the doctor prescribed lithium therapy. Okay. Now, or let me just frame it as a question. So a 65-year-old patient suffering from bipolar disorder was admitted to your unit. The physician ordered what? Lithium therapy to be given the patient 3 times daily. The patient started presenting with bone pain. Okay, the patient started presenting with bone pain, osteoporosis, hypercalcemia, hypophosphatemia. First thing you should think about, or the question I will ask, which condition should you anticipate? The first condition that should come to your mind is what? Is hyperparathyroidism. Do you know why? Lithium has a way of contributing to hyperparathyroidism. Okay. Lithium contributes to reabsorption of calcium in the kidneys. So let's take a note. Okay. Lithium contributes to reabsorption of calcium in the kidneys, thereby increasing your calcium level and then leading to hyperparathyroidism. Okay. So anytime you see a question whereby the patient started taking lithium, then you see signs and symptoms of hyperparathyroidism, you should just know that it is that. Okay. Okay. So the rationale is that lithium contributes to reabsorption of calcium in the renal tubes. Thereby, it stays in the kidney and then it leads to elevated calcium levels. Right. Very good. So that is that for the lithium. Then the sixth one is vitamin D deficiency. I think I've explained this already. Okay. Low vitamin D will not help with calcium absorption. And then when calcium is low and calcium is not well absorbed, the brain must stimulate what? The parathyroid gland must be stimulated in an attempt to correct the hypocalcemia, and thereby increasing more or causing an overreaction of what? The parathyroid gland, leading to more production of parathyroid. Okay, very good. Now, the symptoms of hyperparathyroidism is here. We have bone pain, we have kidney stones, hypercalcemia, hypophosphatemia. So Okay, so let me skip the bone pain. Okay, I will explain the why there is bone pain later when I get to the point 7. Okay, so let me talk about the kidney stones. I'm sure you all know several causes or several types of what of kidney stones. That is what renal calculi, right? You all know this. When calcium begins to build up in the kidneys, leading to renal calculi. So one symptom of what of hyperparathyroidism is what is kidney stones. When there's too much production of the calcium, when there's too much production of the calcium, they begin to lose. Sometimes at a point in time, they begin to build up what in the kidneys, and then this can cause what kidney stones, right? Then 3, we have what hypercalcemia. I've said this several times. Because there's elevated production of parathyroid hormone, they will to increase your calcium levels, right? Then anytime calcium levels are high, phosphate level goes down. Okay. Anytime calcium levels are up, phosphate levels goes down. So there's going to be what? There's going to be hypophosphatemia or low phosphate levels. Okay. Calcium actually it's like they move in hand with phosphate. Okay. And so anytime the parathyroid gland produces more or the parathyroid hormone, calcium level goes down. This will prevent the production of phosphate, rather, okay, thereby decreasing phosphate level. So let's take it. Then 5, we have increased urinary calcium excretion. Okay, increased urinary calcium excretion. Here to compensatory mechanism, just as what we know in diabetes. Okay, you do know why patients urinate a lot in diabetes? Diabetes mellitus, not in DI. I'm not talking about DI. I'm talking about diabetes mellitus. Okay, the reason why they urinate plenty is that there's excess glucose, right? There's elevated glucose level. So to the body, and the body sees the glucose with too much. So the body wants to compensate by excreting the glucose and thereby leading to what? Polyuria, right? So the body will tell itself, Charlie, let me excrete the glucose, let me excrete it, and then this will in turn lead to polyuria. Okay, so in the same way, in this condition, because there's excess production of what? Calcium levels, or there's excess production of calcium, the body will try to get rid of the excess calcium through excretion, okay, through excretion. So the body would now try to urinate more of the calcium. That is why we have increased urinary calcium excretion. Then 6, we have kidney impairment. Of course, if there's renal calculi, or automatically your kidney will be affected. Okay. There can be kidney impairment. Then we have bone resorption, or in other words, bone breakdown. Okay, bone breakdown. Now here, let me explain something over here. Okay. Anytime there is hyperparathyroidism, there is what? Elevated calcium levels. You know what occurs? When the parathyroid gland produces more of the parathyroid hormone, they begin to draw calcium from the bones. Please, let's take note of this very, very well. Okay. Anytime there's hyperparathyroidism, there's excess secretion of parathyroid. Now, when this occurs, they begin to draw calcium from the bones. Calcium is needed in the bones to make the bones strong, right? Very good. So they begin to draw calcium from where? From the bones into the blood. That is one thing that the parathyroid hormone does. Okay, that is one thing the parathyroid hormone does. Right. So when they are secreted in excess, they will pull more of the calcium from the bones into the blood, and then the bone will be deprived of what? The bone will be deprived of calcium. Okay, the bone will begin to be deprived of calcium. So now, when this occurs, the bone will speak to itself, Charlie, no, I have to build a strong bone. Okay, I have to build a strong bone for my body. Okay, I have to build strong bones for my body so that I don't get what? Osteoporosis. So because of this, the body's bone or the bone undergoes a lot of processes, including osteoclast. Okay, osteoclast is what? Is the breakdown of what? The breakdown of bones. The cells that breaks down to form what? Or to help build strong bones, right? So because the parathyroid hormone is drawing more of the calcium from the bones into the blood, the bones are deprived of calcium. Therefore, the body tries to compensate, or the bones try to compensate by breaking itself down in an attempt to produce what or to build up the bone. And then this will lead to bone resorption or bone breaks down. Bone breakdown. Okay. Please, are we okay? I should take it again.
Boss, please take it a bit.
Please take it again.
Okay. Right. Okay. All right. Okay. So let me say this. Okay. When you don't eat calcium rich food, if you don't take calcium rich food, the body secretes parathyroid hormone. You know, you and I, we are healthy patients, or let me say, we are healthy individuals. We don't have anything like hyperparathyroidism. We don't have any condition. So you know something. Anytime you don't eat calcium-rich foods, do you know what occurs? The body will produce what? Parathyroid hormones. Okay. Now, when these parathyroid hormones are being produced, they begin to do what? Pull calcium from the bones into the blood, so that the body can have what? Enough calcium or a bit of calcium in the blood. Okay, that is how it works. That is how it works. So anytime you don't eat calcium-rich food, that is how the body attempts to produce the calcium. They begin to draw calcium from where? From the bones into the blood, so that there can be calcium in the blood. Okay. Now, when the parathyroid gland produces more of the parathyroid hormone, it means that the amount of calcium that will be drawn from the bone into the blood will increase. Okay, will increase because now the hormone is produced in excess. Okay, it will increase. So when it increases, it pulls more of the calcium into the blood, depriving the bone of calcium. Are we okay? It deprives the bone of calcium because now the hormone is bringing all the calcium into the blood, leaving a little in the bones. Okay, so now when it gets to the stage where there is low calcium in the bones, the body will not agree. So the bone begins to go through a lot of reformations, a lot of what? Processes to produce the calcium itself. This is when the body goes through what we call osteoclast, okay, or bone resorption. So the bone will produce cells called osteoclast that will produce what? Or that will begin to break itself down to produce calcium so that the bone will become what? Strong. Now, this is what cause what? Bone resorption, or what we call bone breakdown. Because there is no calcium in the bones, and the bones try to, produce their own or to make themselves strong, they begin to undergo a lot of breakdowns. This is what leads to what? Calcium what? Or bone resorption. Please, are we okay?
Yes, please, it's fine now.
Okay. All right. So this is what we call bone resorption. Okay. Or this is how bone resorption. Okay. Please, only Dennis responded. The rest of us, are we okay?
Yes.
Yes, please.
Yes.
All right.
Okay.
Very, very good. Very good. All right. So because of the excess breakdown, now let's go back to point one. Okay. Because of the excess bone breakdown, the bone will what? Begin to have pains. That is why we have bone pain. Okay. Now you get why I skipped the point one. Okay. So begin to have bone pain. So let's take note. Now 8, osteoporosis. Because down, what is osteoporosis? Osteoporosis is when we have brittle bones, weak bones. Okay, in hyperparathyroidism, what did I say? There is more production of the parathyroid hormone, driving all the calcium from the bones into the blood. So if the bones are left with little calcium, what is going to occur? The bones become weak. Therefore, there is what? Osteoporosis. So let's take note. Okay. Then we have cognitive impairment, we have headaches, and then joint pain. Okay. Excess production of calcium can also affect the brain. Okay, leading to cognitive impairment, causing headache, and then we have joint pain. Of course, if there's osteoporosis, there's excess bone resorptions, your joints will begin to have aches. That is why we have joint pain. Okay. Please, any question over here, or I can continue? Can I continue? I'm sure we are good. Hello.
Hello, please continue.
All right.
Hi. Yes, sir.
Francis, yes.
Please, I'm a little bit confused about being the body having more calcium, and then there will be problem with the bones. Whilst we also know that low calcium will lead to uh, brittle bones or weak bones. So I'm still having challenge to understand that scenario over there.
Can you please come again with your question? Okay.
Yeah, I said that we know that when there is low calcium in the body, the bones will be weak.
Yes.
The bones will be weak. But here, as the case, we have the parathyroidism also, or
I
the
get it.
parathyroid gland. Sorry, the parathyroid gland producing more calcium for the body, and yet it will be drawing more all the calcium from the bones rather to the blood, and then leaving problem with the bones having been the bones being weak. I still don't get it why it is so.
Okay. I don't know if my explanations have been. You can understand.
So here, what of if there is low calcium in the body too? Would there be still problem with the bones being weak?
Yes. If there's no calcium in
Uh-huh.
the body, the bone will also be weak. Yes.
Yes, and here as the case, there's more parathyroid glands producing more calcium, and still the bones are weak. So it's making some confusion.
Yes. Okay. So when there is it's how the parathyroid gland works. Okay, madam. Is it Amasaki based on maybe she wants Ama, please.
So I want to think that in this case, there's calcium, okay? But then the calcium is not getting to where it can be utilized, which is the bone.
Yes, the bones.
Very
The distance of the bone. Yes.
good.
Please, can I clarify something here?
Yes, please.
Yes, when you started with the explanation, like when we started parathyroidism, yes, you did mention that
Everyone have issue pronouncing the condition.
hyperparathyroidism, yeah, hyperparathyroidism, yes. So you said that it's a condition, and one or more of the four glands, the parathyroid glands, become overreactive and they produce excess parathyroid hormones.
Yes.
And you said I want to be clear on something. The parathyroid glands, they produce the parathyroid hormones, right?
Yes.
And the hormones regulate the calcium levels.
Yes.
Thank you. That's what I want to say.
Okay, right. So that is it. Okay, the hormones regulate the calcium levels. Okay. So how do I put it, Mr. Francis? When usually, before a patient can get, that is why we did the courses. Please, let's think of the causes of it. Okay. Before a patient can get hyperparathyroidism, usually, it is because the patient does not have enough calcium, usually. Okay. That is when the body tries to stimulate itself and then begin to draw the calcium from the bones. If you have enough calcium, there will be no hyperparathyroidism. Let's say, let me ask this question. Please, what's the normal range for calcium?
8.5 to 10.10.
It's 8.5 to 10.6 hours.
Right. So let's take this. I know different books have different values, but please let's stick to this. 8.6 to 10.2 milligram per deciliter. Okay, mg per dl. 8.6 to 10.2 milligram per deciliter. So if you have a calcium level,
Your line is breaking.
sorry, is it okay
Please,
now?
can you come again? It's unclear.
Can you hear me now? Hello, can you hear me now?
Yes.
It is 8.6 to 10.2 milligram per deciliter. Okay, 8.6 to 10.2 milligram per deciliter. Okay, very good. Now, when you have a normal calcium level, let's say 8.9 or let's say 10.0, there will be no condition or there will be no causes of what? Hyperparathyroidism. Nothing will set in, you'll be fine. Okay. But the moment your calcium level starts dropping below 8.6, so we start getting 8.0, 7.5, then the body is having low calcium levels, right? So there will be stimulations of calcium. Then the body will try to stimulate itself, produce more parathyroid hormone. Here is when the body will what? The body will now take a lawyer. Okay, the body will now try to take a lawyer. So one of the lawyers is the bone. So please, if I'm not having enough calcium, why don't I reach out to the bone, bring the calcium in the bone into the blood, so that will be okay. That is when the bones begins to become affected. Okay, please, are you okay, Mr. Francis? Yes,
Yes,
that is
sir.
how that is how it begins to work. Okay, that is how it begins to work. But then if you have hypoparathyroidism or low calcium, for that one, your body is deprived of calcium automatically. So therefore, even calcium levels in your bones also begins to drop. Okay. So please let's take note of that one. That differentiations as Madam Sarah, yes, your hand is up.
Yeah, so I want some clarification. I wanted to find out where is the calcium produced? Where exactly? Because if the parathyroid gland is regulating it, is it the same place that is producing the calcium?
Yes.
Otherwise, then when we are looking for when there is reduction of the bones of the calcium in the bones, then does it mean that's the compensatory mechanism for the calcium reduction in the blood?
In the blood, yes. That is it. Okay, that is it. Okay, that is it.
Hello, can I come in here? So please, I I want to get something. So the parathyroid hormones are or that is it regulates the calcium levels. So for instance, if the calcium levels are in excess, the parathyroid hormone can excrete some.
When you said when what?
The calcium levels are in excess.
You're asking the parathyroid can excrete some. No, the kidney will now excrete some, not the parathyroid hormone.
Okay, so it's rather going to be excretion and not reabsorption like in storage.
Yes.
Mm.
And then please let's take note of that. The main in our body, the main storage site for calcium is our bones. Let's take note. Okay. The main storage site for calcium levels is our bone. That is why anytime you have low calcium, the body will reach out to the bone to bring some to the blood. Okay. But then chiefly or primarily, we produce calcium through eating. Primarily, we get calcium in our body by eating it and then being absorbed in the small intestine. That is when we begin to have calcium level goes up. Okay. So please let's take note. Then the parathyroid hormone will come in to regulate their levels. Okay. Regulate their levels. All right. Please, are we okay? Can we talk about the diagnosis? Hello, class.
Yeah, let's go.
Okay, all right. The diagnosis, by diagnosis, first we have to look out for what? The serum calcium levels, right? So I made mention that the normal one is 8.6 to 10.2. Okay, so anytime it goes below 8.6, then we know that what there is what? There is hypo, or there's what? So if the calcium level goes up above 10.2, okay, when the calcium level goes above 10.2, that is hypercalcemia. Okay, because the what do you call it? The parathyroid gland is producing more of the parathyroid hormone, secreting or regulating, keeping more of the calcium levels. Okay, then we have what? We have hypercalcemia. Then we can also draw blood, right? We can also draw blood to check the levels of the parathyroid hormone, right? It is the normal value. Okay, maybe you can write it down. Okay, the normal value for parathyroid hormone, but I doubt it will be asked on the English anyway. The normal value for parathyroid hormone is 6. Okay, is 6 to is 6, or let me see. No, it's 10 rather. 10 to 60 picograms per milliliter. Okay, 10 to 60 picograms per milliliter. That is 10 to 60 pj per ml. Okay, pj, that is picograms. 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 Okay, picograms per milliliter ml. That is the normal value. Okay, and in this patient, when we draw the parathyroid levels, it's going to go up. Okay, it's going to be high. levels of the parathyroid hormones. Then also check phosphate levels. Here it's going to go down. So I have another question. The normal value for phosphate is what? Phosphorus. Normal value for phosphorus.
Isn't it 2.5 to 3.5? Oh, I'm mistaken. I think it's 1.5.
Phosphorus.
It's 1.5 to 4.5.
Wow.
2.5 to 4.5.
2.5 to 4.5.
Yes, yes. You all have our values, okay? Because there's lab values. There's lab values. You know, every book has its own. But then, yeah, usually it should be +2 -2. Okay, so 2.5 to 4.5. The normal values for phosphate. And then in this patient, phosphate level is going to go down. Okay, the phosphate level is going to go down. All right. Then you can do urine calcium excretion test. Okay, so there we take the sample of the patient. Okay, you take a urine sample. Okay, but this particular test, they use the 24-hour urine collection to do it. Okay, so you are going to use the 24-hour urine collection. The procedure, the pattern. You take the urine and then you test for the presence of calcium in the urine. So if you see high levels of calcium in the urine, then you can also conclude that there's hyperparathyroidism. Then imaging studies and then bone density scan. So imaging studies, you can do ultrasound, CT scan, MRI. You do that one to do what? To visualize the parathyroid gland very well. So you can take a CT scan of the glands and check if they are having a normal cells, the cells are being proliferated, there are any cancerous cells over there. That is how we do the imaging. Yes, madam. Or I don't know, but I don't know whether it's a fellow. Sorry.
Yeah, please.
Yeah.
So with
Hello. Hello.
the urine, seeing that. Hello, I'm saying with the urine.
Yes.
Hello.
Yeah. Hello.
Yeah, with
Please.
the urine.
Hmm.
When you notice calcium oxalate, the presence of calcium oxalate in the urine, does it also signify that there is increased calcium level?
Yes. 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 That one too can help you identify.
Okay.
Yes, that excess is a calcium production. Yes. And then even that one should start prompting you of an impending calcium renal calculi. Okay. That one should start prompting of an impending renal calculi. Okay. Very good. Then you have the imaging studies, then the bone density scan. So the bone density scan, usually it is done to do what? To diagnose osteoporosis. Okay. And then here, because you are going to get osteoporosis, what do you have? What are you going to see? Usually the bone density scan will be a bit low. Okay. The bone density scan will be a bit low. Okay. The bone density scan will be a bit low. But we are going to have a weakened or low density low density for the bones when it comes to this. All right. So surgery, the treatment. Now I talk about the treatment. Okay, the treatment. So we can do a surgical procedure. That is a parathyroidectomy. Okay, parathyroidectomy. That is removal of the affected glands. Okay, removal of the affected gland or glands. So if the situation is getting out of hand, there's still more production of parathyroid hormone, you can schedule a surgical procedure. Okay, and then you go and take off the parathyroid glands. Okay. So surgical procedure can be done. Then medical management, we have the drug, the biphosphonate, the sinacalate, okay, or sinacalate, sorry, okay. And these drugs can also be given to correct the situation, okay. The biphosphonate, biphosphonate, in this condition, there's low phosphate levels, right? So when you give the phosphate, what does it do? It binds with calcium and then it becomes excreted, right? So one thing you should know is that biphosphate can be given once you increase the levels of biphosphonate, calcium level will begin to drop. Okay, calcium level will begin to drop. I'll ask a question on this. I'll ask you a question on this. I'm coming. Then the Sina set, okay, or Sina set. This one can also be given to reduce the amount of hormone being produced, okay. Reduce the amount of hormone being. Then we have the hormone replacement therapy. Now, someone can ask a question: why is it that here you have to replace hormone? Okay. Now, let's take note. One major cause, one other cause of the hyperparathyroidism is also hypoparathyroidism. Okay, because anytime the hormone is not produced well, or anytime the hormone is not produced enough, the body will try to compensate, and that alone can contribute to what? The hyperparathyroidism. Okay, so anytime we see what do you call it, a hyperparathyroidism, we can give a replacement of the hormone, okay, to correct what the condition and prevent future hyperparathyroidism. Madam Genevieve.
Yeah, I just wanted to ask about the surgery. If one of the affected glands is removed, does it affect the effectiveness of the other three glands?
Not necessarily, okay. One of them can be removed, but then what is going to occur is that the production of the hormone will be affected because there are four, and then all these four helps to produce the parathyroid hormone enough for the body. So anytime one of them or two, or let me say anytime one become affected and the one becomes removed, it simply means that we are not going to get enough of the parathyroid hormones, okay. But then it might not necessarily affect the other three. The other three can still be healthy, just that the production of the hormone will be affected. Okay.
Okay, thank you.
Okay. All right. Then we have lifestyle modifications. Okay. So we have dietary changes. These patients already have high calcium level. Okay. So what do you have? They must consume a low calcium meal, right? But then a high phosphate, because of the low phosphate, they must rather produce or consume a high phosphate meals. Then they must increase fluid intake. This fluid intake will help in a lot of situations. One, it will prevent renal calculi. Okay, so if you consume more fluid or you take in more water, it can ensure that the calcium being built up in the kidneys are being excreted. Okay, and then two, if there's excess calcium in the body and then you take in more water or you increase fluid intake, it can also help the kidney function properly by excreting the excess calcium levels. Okay, very good. Then we have regular exercises. So regular exercise can also help the absorption of calcium and then maintaining a normal calcium levels. Okay, very good. Then I have some questions to ask over here. Let me see. Okay, I have some questions to ask over here. Right. So first question is on alendronate. When you are taking, I think we did this the previous topics, right? When you are taking alendronate, if I'm right, when you are taking alendronate, when you are taking alendronate, how should you take it? Should you take it with 2 glasses of water? Someone can help me. I don't want to give the hint on the answers. So when you hear alendronate, with regards to alendronate, pharmacological wise on NCLEX, what comes into mind? Please, someone should help us. Hello.
Okay, hello.
Yes, Madam Mr. Dennis. Yes.
Okay, so with regards to alendronate, it is taken on an empty
Hello.
stomach.
Please let's Madam let's Mr. Dennis finish. Okay, when he's done, you come in.
Okay, so it is taken on an empty stomach with a full glass of water, and
Okay.
usually the advice is contraindicated in clients or patients who cannot sit up after you have taken the medication.
Okay.
Yeah.
Okay. Okay. And then why is it contraindicated in patients who cannot sit up? Why?
Okay, because it would cause osteophagitis. Sorry, esophageal
esophagitis.
Esophagitis. Yeah, sorry.
Esophagitis.
Yeah.
Yes. Any other? So Mr. Dennis is right. Any other? So you take this water with full glass of you take this drug with full glass of water. And then the moment you take it, you have to sit upright for 30 minutes before lying down. Okay, before lying down, because if you lie down right away after taking it, it will regurgitate and it can cause esophagitis. It will cause irritations in the lining in the esophagus. So please, let's take note. Okay. Any other to add up with regards to LN units? Any other to add up? Or these are the areas that the NCLEX like.
Hello.
Yes, Madam Juliet.
Yes, we must also alert the healthcare provider if the patient is on alendronate and the patient has to go for an ECT, electroconvulsive therapy, because of the weak bones.
Okay. All right. Thank you for that. Okay, so let's continue to read more, and then I think these are some of the areas that the NCLEX like to bring on the NCLEX. Now let's come to diet. Okay, my next question is on diet. So this one, please, I want us to talk about diet that is high in vitamin D. Okay, because vitamin D will help it. So we all know that vitamin D deficiency contributes to hyperparathyroidism. Okay. We all know that vitamin D deficiency can contribute to hyperparathyroidism. Please, let's take note. The moment the condition starts occurring with diagnosis of hyperparathyroidism, we have to limit vitamin D also, because vitamin D contributes to calcium absorption. Okay. Unless primarily the cause is significantly the vitamin D, then we have to make sure that we are correcting the vitamin D deficiency so that the body will stop producing or will stop removing more of the calcium from the bones. Okay. So one major cause of vitamin D, hyperparathyroidism is vitamin D deficiency. So I want us to list some of the examples of vitamin D rich foods. Okay, please. Can we list some of the examples of vitamin D rich foods? So that in an attempt to prevent this condition, we can now start taking them. Even you and I can start taking them to prevent hyperparathyroidism. Can we list some of the vitamin D rich foods? Hello.
Dairy products.
Dairy products.
Dairy products.
Example.
Milk.
Milk.
Cheese.
What? Meat.
Cheese.
Cheese. Okay. All right. Milk, cheese. Let me see.
Yogurt.
Kako. Is that what? Vitamin D rich. Okay, so these are examples of vitamin D. Okay. So I think this one is a bit clear.
Egg.
Yes, please let's take note of them, because on the NCLEX, they will not go and just write take in vitamin D rich foods. No, they will rather bring examples of them for you to know them. Okay. They will rather bring examples for you to select them. They will not do what, just list or say it glance like that. Okay. And so these are examples of them. We have fatty fish. We can write them down. Okay. Fatty fish, cod liver oil, mushrooms, egg yolks, fortified foods, beef, liver, cheese, tofu, pork, and then yogurt. Okay. Pork and then yogurt. All these foods are rich in vitamin D. All these foods are rich in vitamin D. Okay. So let's take then. You can also look at vitamin, so calcium, rich calcium, calcium. We have the calcium rich foods. We have milk. I think we have crab as well. Okay. So they are here. The calcium-rich foods are also here. Okay, milk, crab, drumstick leaves. Okay, soya beans. Okay, so these are also the calcium-rich foods. Let's take that one to consideration. Very important. Good. Now let's talk about the complications of hyperparathyroidism. So we have this, I think this one I have made mention of one of them when I was explaining myself, right? We have kidney damage, we have osteoporosis, we have cognitive impairment. I think this one I was talking about them, right? Then cardiovascular disease. We all know calcium can really have an effect on the heart. Okay. Yeah, we all know that. Even if there can be calcium deposits in the arteries. Let's take note, okay. When there's too much calcium, there can be calcium deposits in the arteries. They can even contribute to coronary artery disease. Okay. And when there are too much calcium deposits in the arteries, it can interfere with blood flow and then it can put pressure on the heart. Okay, so let's take. Then we have pancreatitis and peptic ulcer disorder. How does hyperparathyroidism contribute to pancreatitis? Okay, so anytime you have more calcium or high calcium levels, it activates what we call trypsinogen. Okay, it leads to the activation of trypsinogen into trypsin. So let's take a note. Okay, it leads to the activation of trypsinogen into trypsin, and then when this occurs, when there's more production of trypsin, it causes autodigestion of in the pancreas, and that can lead to pancreatitis. Okay, so I'm taking it again. Excess calcium production can cause the activation of trypsinogen into trypsin. When this occurs, there's an autodigestion in the pancreas, leading to pancreatitis. Okay. Then peptic ulcer disease, the same idea. When there is a lot of calcium levels in the blood and there is more production of this enzyme, it is called gastrin, like gas, and then we add TRIN. Okay, gastrin. Okay, when this gastrin is also produced in excess, it will begin to have irritations in the stomach lining, leading to what? Peptic ulcer. So that is that for hyperparathyroidism. We are going to talk about the opposite of it. Please, any question before we talk about the opposite? That is hypoparathyroidism.
Sir,
Yes.
please, is it advisable to do calcitonin in hyperparathyroidism?
No, in hyperparathyroidism, you rather okay, calcitonin reduces calcium levels, right?
Yes.
Yeah, so you can give it. Yes. Calcitonin can be given to reduce calcium levels, so you can give it.
Okay.
Yes. Yes. All right. Yes, within another question. Our contribution.
Hello, Wasaki.
Subtraction. Yes, Madam Jane.
Yes, can you have hypercalcemia without the parathyroid hormone being affected?
We have hypercalcemia. One thing is that how do I even say it? Okay, so let's say you are a type of person, you eat a lot of crabs, okay, and then crabs is rich in what? They are rich in what? Calcium. So
Calcium.
yes, so when you take in more calcium rich, automatically you are going to get what? Hypercalcemia. That is anytime you draw the blood, because you are taking more of the calcium, you are going to get what? Hypercalcemia. So usually they don't really have a clear, effect on the parathyroid hormone. No. Okay. But please take note. I want to say something. Okay. One thing that's going to resolve later is that because what do you call it? Because the parathyroid hormone is responsible to regulate calcium level, it will maybe try to now bring the calcium levels down. Okay, that is when it can cause the parathyroid gland to secrete more of the parathyroid hormone. Okay, when you consume more calcium-rich foods, they will stay in the blood, so there will be hypercalcemia. Now, the parathyroid hormone is responsible to check the balance of calcium. So, in an attempt to regulate the calcium level by bringing it down, by stimulating the kidneys to excrete it, here it can contribute or it can cause the parathyroid gland to produce more of the parathyroid hormone in an attempt to bring the calcium levels down. So therefore, it can contribute to excess production of the parathyroid hormone. Okay. Yes. This endocrine system, that is how they are. That is how they are. Especially, let me even say this. Do you know hypoparathyroidism can cause hyperthyroidism? Sorry, hypothyroidism can cause hyperthyroidism. Because when you have low production of the thyroid hormone, the body will stimulate itself to try to compensate, and that will cause hyperthyroidism. Okay. And then if you have hyperthyroidism too, that is more production of the thyroid hormone. Even though it is rare, later it can cause hypothyroidism. Okay, because anytime there is low production of the thyroid hormone, the thyroid hormone stop producing it itself, or the thyroid gland stop producing the thyroid hormone. Okay, because they don't need more. Already there is more. You don't need more, right? That is when if you start treating it, then you start pushing the patient into what? Into hypothyroidism. Okay, so that is how the endocrine system it looks like. Okay, you have to understand it that way. Okay, very good. Very good. That is it. Please, any other question, subtraction or addition, confusion? Once we talk about the opposite of hyperparathyroidism. Hello, are you okay? Most of us are fine.
Yes, so
Yeah, 107 over here. I can hear some few voices. Please, are we all okay?
yes, sir.
Yes, please, we are fine.
Okay. All right. Then I can talk about the hypoparathyroidism. Right. So this one we will not waste time. Okay, because I think we've done a lot of the work in the hypoparathyroidism. So now that we are talking about the opposite, we are just trying to link it with the hyper. Okay. So in hypoparathyroidism, what do we see? We see that one too is a rare endocrine disorder characterized by what? Underactive parathyroid gland, leading to what? Insufficient production of parathyroid hormone and then hypocalcemia. Okay. Insufficient production of parathyroid and then hypocalcemia. So in this one too, the parathyroid gland is not producing more of the parathyroid hormone. Okay, so there will be low levels of what? Of your calcium, and then high levels of what? Of your phosphorus. It's as simple as that. So we have the types. Okay, the types. You have the primary hypoparathyroidism. That is the most common form, usually caused by surgical removal of the parathyroid gland. So that is what I was trying to explain in response to Madam Genevieve's question. Okay, so if we do what? Parathyroidectomy, okay, and then we take off any of the glands of the parathyroid gland, then if we take it off, automatically, there's going to be an underproduction of what? Of the parathyroid hormone. Okay. So surgery, when you do a surgery to remove the parathyroid gland, it's going to cause a significant effect on the production of what? Of the parathyroid. Okay. Then we have autoimmune disorders. Okay, there can be sometimes there can be release of antibodies. Okay, that is autoimmune. The body itself, immune system begins to fight against the body. So when the immune system is being triggered, right, it begins to secrete more of antibodies. Then these antibodies will begin to distract. Okay, will begin to distract the thyroid glands, the cells in the thyroid gland. So when this autoimmune disorders, the antibodies distract or destroys it destroys the cells in the parathyroid gland. Obviously, automatically, there will be low production of what? Of the parathyroid hormone. Okay. Then we have genetic mutations. Then we have radiation therapy. Of course, if you are exposed to a lot of radiations can kill the cells over there. I'm sure we all know that, like X-rays, like we have X-rays, like CT scans, MRIs. Okay, you know all these machines use rays. Okay, or when we're exposed to too much rays, it can kill the cells over there and it can affect the production of what? Parathyroid. Then you have secondary hypoparathyroidism. You have magnesium deficiency, vitamin. So you see here too, you have vitamin D deficiency. So here too, because we don't have a lot of vitamin D, what is going to occur? There's going to be low calcium absorption. I said that vitamin D helps with what? Helps with calcium absorption. So anytime there is low vitamin D levels or vitamin D deficiency, calcium will not be absorbed, and this can also contribute to hypoparathyroidism. You see how or this condition, it's their behavior. Okay. And then magnesium deficiency. Actually, magnesium, or let me say, magnesium helps the parathyroid gland to synthesize parathyroid. Let's take note, okay? Magnesium. Magnesium helps the parathyroid gland, okay, synthesize parathyroid hormone. So anytime there is low levels of the magnesium, the synthesis of the parathyroid hormone will be low, okay, and then we have what? Hypoparathyroidism. Then here too, you see, we are getting chronic kidney disease as well over here. So how do you think this one is going to contribute to this? So here too, when you have chronic kidney disease, okay, and then the kidney is not being able to reabsorb calcium levels very well, okay, or there's a disease in the kidney, not helping the renal tubes absorb calcium very, very well, or reabsorb calcium very, very well. That one too can do what? Can contribute to what? Hypoparathyroidism. So they look similar, but then in respect to the condition, they have different what? Explanations. Okay. They have different explanations. All right, good. Then we have tertiary hypoparathyroidism. That one develops from secondary, and then we have the genetics. Okay. All right. All right. Then let's talk about the causes. I think the cause is the same as the types. The surgical removal of the parathyroid gland, that is the parathyroidectomy. Okay, the parathyroidectomy. That is the common cause. The moment the patient undergoes surgery and takes even one of the parathyroid gland, production of the parathyroid hormone will be affected. Okay, production of the parathyroid hormone will be affected. Okay, production of the parathyroid will be affected. Then we have the autoimmune disorder I was speaking about, the autoimmune hypoparathyroidism. So here there is production of antibodies. The antibodies will try to destroy the cells in the parathyroid gland, therefore contribute to low productions of the parathyroid. Genetic mutations, example is the DIE or the George syndrome. We have radiation therapy exposed to X-rays, the magnesium deficiency, vitamin D deficiency, and chronic kidney disease, as I explained later. Okay, or I explained earlier, sorry, as I explained earlier. Okay. All right. Please, do you have any question? Do you have any question? Oh, we are good.
Yeah, I have a question, I think.
Okay, yes, please can ask me.
Now, please, I want to ask about this vitamin D helping calcium absorption. Does it help calcium to be absorbed in the blood?
In the intestine. Yeah, absorbed in the intestine.
Yeah, no. Okay, absorb from the intestine to the blood, right?
No, calcium is should I say calcium? Calcium is needed though. Okay, from time to time, you need calcium for strong what? For strong teeth and for strong bones. Okay, we need calcium in our body for strong teeth and strong bones. Okay, so you have to take in calcium-rich foods all the time so that our bones will be strong, our teeth will also be strong. So to help contribute to this effect, anytime we eat calcium, it should be absorbed in the intestine so that it can now be transferred and help with the strengthening of your bones and the teeth, not necessarily being in the blood. Okay, if the calcium levels continually be transferred into the blood, it will increase your calcium levels. Okay, So even though when we draw the calcium, serum calcium level, we should be getting 8.6 to 10.2, and 8.6 to 10.2. It is well understood that way. But then if the calcium levels are continually being transferred into the blood, it's going to go up. So once it gets into the intestine, it goes into the blood for a while so that it can help with what? With the or it stays in the blood for a while so that it can help with the what do you call it? Let me see, the strong bones and strong teeth. The moment the calcium level begins to or tries to go up, the kidney will do what? Will try to excrete some of them, okay, so that you maintain a normal serum calcium levels. So primarily, calciums are absorbed in the intestine, later being used, okay, by the body for strong bones and strong teeth, okay. Thank you. Yes, yes. But we all know that blood supply contributes, let me say, almost every function in our body is about blood supply, right? That is why you should get some of the calcium, or the calcium should be transferred to the blood so that when the blood is being pumped, supply the nerves, supply the arteries, the cells responsible for this strong bones and strong teeth. Some of the calcium will be distributed to these areas to ensure the strong bones and strong teeth. Okay. So we should know that. All right. Madam Sarah, I saw your hand.
Yeah, I wanted to find out among hyperthyroidism and then hyperparathyroidism, which one calls for the removal of the glands? Like, which one do we have to, if we have to make a decision? Because when you remove one, it affects the other. So is there a way that maybe we can still save a gland among these two conditions?
Please, can you come again with your question?
So I wanted to find out, so with a condition with hyperparathyroidism and then hyperthyroidism, so the opposite of these conditions.
Okay.
Yes, I wanted to find out which one, when we have to make a decision to remove the gland, which one.
Okay, you please continue.
Yes, so among these, they're both hyperparathyroidism and then hyperthyroidism. If we have two patients with these conditions and we have to make a decision on the thyroid gland, which one, like, can we hold on for a while if we have to remove a gland, considering the two conditions?
Okay, so if I'm getting you, or you want to ask that if a patient have hyperthyroidism and hyperparathyroidism,
Yes.
you want to do a surgery, right?
Yes.
So meaning the patient is having these two conditions at the same time?
No, so I'm not sure they will have the same condition at the same time. But you see, we want to, if we have to make a surgical decision to save a gland concerning like these two conditions, which one can we hold on for a while? If the patient is suffering from hyperthyroidism or hyperthyroidism.
I don't know what
Hypothyroidism.
Get hypothyroidism. Why?
Hello.
Yes, Madam Mr. Kabiru, sorry.
She's asking between hypoparathyroidism and then hyperparathyroidism.
Is that what she's asking between hyperthyroidism and hyperparathyroidism?
Parathyroidism. Yes, for that too.
It's not the opposite of
please let me come in a bit. I think if I understand her right, let's say if we have two patients suffering, one suffering from hyperthyroidism and then one from hyperparathyroidism, and then you have to remove the parathyroid glands for one and then the thyroid gland for another. Which one would you can you like keep? Like, which one is urgent?
Delay.
Which one must you, yes, which one must you remove? Must you remove the thyroid gland? Since when you, for the hyperthyroidism, if you have to remove the thyroid glands, it also affects the parathyroid glands. If I understand what she's saying.
Oh, okay.
Yeah, exactly what I mean. Yeah.
But we have two different conditions, so each of them have their problem. Okay. Unless maybe you are asking that if someone have, let's say, hyperthyroidism and hyperparathyroidism at the same time, Okay, but then if you are trying to compare two patients, then they are different. Each of them is different, and then you respond to the situation as and when the patient is presenting with a particular condition. Okay, but then if you want to say in terms of priority, thyroid gland and parathyroid gland, which one takes priority? This one, each of them is important. Okay, because parathyroid gland helps in calcium regulation, and then thyroid gland also helps in what? In metabolic regulation, right? It helps regulate your metabolic rate very well. So each of them have what? Have their own significance on the body. So in terms of priority, I can't say if one is taking a higher priority over the other. They are all important. I don't know if this answers your question. This answer your question. I'm still not getting the question.
Yes. Yeah, not really, but I wanted to find out in case the patient is suffering from the same condition. I'm sure when we remove it, then it will automatically solve the situation for that patient. But when we have to say the gland, like with that same condition, and we want to make a decision to say the gland, is it because I'm thinking then maybe the hyperthyroidism will be better because that will cause a more like a crisis than the hyperparathyroidism as discussed right now, if I want to make a decision. I don't know.
Okay. So you want to make a decision if the patient is suffering from that is what I'm trying to say. It should be on the same patient. Then you can decide which one are we going to do first or which one are we doing. Okay. So the patient have hyperparathyroidism and then hyperthyroidism at the same time. Then we want to do a surgery to remove the gland. So which glands we do decide to take off? Okay. Then you are saying we should take off the thyroidectomy, right? Because the thyroid gland first, because that one can cause crisis. Then for me, I think each of them is significant. Okay.
Important.
Yes, each of them is important. You can't rate one over the other. Okay. And then let's take note when the surgery is being done. Usually, we give them the supplement to take for life. Okay, so even if the patient is suffering from the two conditions at the same time, and we take both glands out, both the thyroid gland and the parathyroid glands out, the patient will not produce enough of them. So the only option is to produce what or to give a hormonal therapy for life, so that the patient will take it for life. Okay. All right.
Yeah, thank you.
But
Yes, Madam G.
if someone is suffering from hyperthyroidism and you are taking the thyroid gland, can you maintain the parathyroid gland?
Usually, that is what is believed. But then, in most cases, they accidentally take off the parathyroid gland. Most cases,
Exactly.
yes, in most cases, they accidentally take off the parathyroid gland. Yeah. All right. So the signs and symptoms of what do you call it? Hypoparathyroidism. We have the hypocalcemia, which we all know because there is low production of parathyroid. We have what? Hyperphosphatemia. Okay, because I said it, anytime the calcium levels are low, phosphate goes up. Okay, and anytime phosphate levels are low, calcium goes up. Then we have the key sign and symptom of hypocalcemia, Straussian sign, and then Schiff-Foxtec sign. Okay, now, did I pronounce it well? Please, someone show the pronunciation. Is it Straussian or I pronounce it Straussian sign?
Shozo sign.
Joseph sign.
Shozo sign. Yeah.
Joseph sign. You. I mean, I remember my teacher.
The sign is not there.
He said what?
Just remember
The
trouser.
other one.
Yeah, exactly. Yeah, the other one is not there, but you should know that it's part of the signs of hypocalcemia. Okay. Yes, Straussian. Me, I pronounce it Straussian sign. I remember back in school, my teacher used to tell me, depending on where you completed your SHS or your primary school, okay. Depending on where I completed my primary school, those people went to Saito, we say it's Straussian sign. Okay. Let me show a picture of it so that Straussian sign and then Schiff-Foxtec sign. Okay. Then let me add the rest. Schiff-Foxtec. And You can't talk about hypocalcemia on NCLEX without these two. Okay. Always you have to talk about this. Okay. Always have to talk about this. Always don't talk about hypocalcemia. You have to talk about these two signs and symptoms. Okay. Gaussier sign and then Chief-Fox sign. Okay. Gaussier sign and then Chief-Fox sign. Oh, this Gaussier sign and then Chief-Fox sign. Okay. But how do we elicit or how do we see each of them? Okay. Or per the pictures that I am trying to display, which of them is the Gaussier sign and which of them is the Chief-Fox sign? Okay. My listing is not helping. Okay, so depending on this picture, let's look at this picture. Okay, the one here. Depending on it, which of them is the Gaussier sign, which of them is the Chief-Fox sign?
The Chaucer sign
With the
is in the hand.
Please,
The
the
spasm in
hand
the
is
hand.
the hand is the trouser sign.
The hand is the trouser sign.
you know the thing I want to say. Please, can one
The
person?
trouser sign is the one when the calf is applied and inflated. You realize that the palm is being kind of like spasm, which is being turned inward. So that's the trousers.
How long should you apply the calf for you to see? How long?
Please, I've forgotten.
Okay. Someone should help us. How long? How many minutes? How many? So it's
I
3
think
minutes.
it's 3 minutes.
Yes, 3 minutes. Okay.
Mm.
So when you apply the calf, and then when it gets 3 minutes to 4 minutes, you start seeing that the hand is shaking. Okay. And that one is the Gaussier sign. Then when it hits the chin, okay, or let me say the jaw, the area under the jaw, around below your eyes, okay, you see some spasms on the face. Then this is what we call the Fox sign. Okay, I'm sure you all know the reason is that calcium, okay, calcium actually helps calm your muscles down. Please take note. Calcium, when you have calcium in your blood, it helps to calm your muscle down. So anytime there's low calcium, there's muscle excitability. Now your muscle begins to exaggerate because there's no calcium to calm your muscle down. That is why we get these spasms on the face, the tetany and all those stuff. Okay, and there's no calcium to calm your muscles down. Okay, so let's take note of that. All right. So we have the Gaussier sign, supported sign. Then we have decreased urinary calcium excretion because there's low calcium here. The kidney will try to hold the calcium. Okay, the kidney will try to hold the calcium to elevate the calcium levels, right? So therefore, we have what? We have decreased calcium excretion through the urine. Then we have muscle cramps. I've spoken about it just now. Muscle cramps. Okay, because there's no calcium to calm down the muscles, right? Then you have muscle weakness. If you have consistent cramps, consistent spasms of your muscle, there's going to be muscle weakness, right? There's good fatigue as well. Then numbness and tingling. There can be seizures and then tetany. Okay, all these things can exaggerate, especially the seizures. Okay, it can exaggerate. What do you call it? The brain functioning. Okay, it can exaggerate the brain functioning. Can contribute to what? Can contribute to seizures. Okay, so these are the signs and symptoms of hypo. And at least, if nothing, you should know that you are dealing with calcium. So here, all signs and symptoms of hypocalcemia goes here. Okay. Then diagnosis the same as what we treated under the hyperparathyroidism. Okay. So here too, there's serum calcium levels. So here it's going to be low, below 8.6. Okay, below 8.6. Then we do parathyroid hormone levels as well. I said that the normal parathyroid hormone was what? 10 to 60 picograms per milliliter, right? So here it's going to be low. Okay. Then phosphate level is going to be high. Usually in this condition, magnesium levels are low. Okay. Since we've not spoken about magnesium levels, can someone help us? What's the normal value for magnesium?
1.5 to 2.5.
2.5. Okay. Very good. as the normal value for magnesium. Okay. All right. Then we can also do urine calcium excretion test. Okay, to check for the presence of calcium in the urine, and in this instance too, it's going to be low. Then we can do our imaging studies and our bone density scan as well. Okay, our imaging studies, then our bone density. All right. Okay, someone is writing on my screen. All right, so the treatment is here. Okay, the treatment must give what? Calcium supplement, right? You must give calcium supplements. So calcium gluconate and calcium citrate. Okay, calcium gluconate and calcium. Madam Vivian, yes.
Okay, so please, for the hypo, what will be the bone density result?
Okay. Can someone help us? This is a question. I want to throw it to the class. Can someone help us? Someone should help us. Okay. Someone should help us.
Hello.
Yes.
I'm thinking the bone density will be rather high because the tissues have taken the calcium. That's why the blood level is low.
Are you sure? We don't have calcium. We don't have vitamin D.
I think
So
we'll
that's
still have
no.
I think we'll still have a low density bone because once calcium
Yes.
levels are low, once calcium levels are low, the bone will not be strong enough.
Yeah. Yeah.
The body.
Of course, you are right. So the bone density is going to be low, but then what is going to occur here is that there's going to be increased bone mineralization. Anytime you take the supplement like calcium, vitamin D, the body will try to push all the minerals into the bones. Okay, simply because you want to increase the bone density. Okay, so let's take note. There's still a low bone density, but then an increased bone mineralization, like minerals will now be deposited a lot into the bones to increase the bone density. All right, let's take. So we can give calcium supplements like calcium gluconate, calcium citrate. Then we give vitamin D supplements. Vitamin D supplements helps with calcium absorption. Let's not forget. Okay, it helps with calcium absorption. So we have what? Ergo-calciferol and then cholecalciferol. Okay, ergo-calciferol and then cholecalciferol. Okay. Then you give what? A low phosphorus diet. Of course, there is high phosphorus over here. You must give a low phosphorus diet. Okay. Then you give a hormone replacement therapy. That example of them is the teriparatide, okay, or the teriparatide. This is a hormone we give to replace or to increase the parathyroid hormone levels. Okay, you can give this hormone as well, the teriparatide. Okay, that is an example of the parathyroid hormone. Then lifestyle modification, you must increase high calcium and vitamin D rich foods. Okay, I've said it earlier. Then you exercise regularly, then you ensure that you are managing your stress very, very well. Okay. You exercise regularly, and then you ensure that you are doing what? You are managing your stress level very, very well. Okay. Then you institute seizure precautions because there can be seizures. Anytime there's hypocalcemia, there can be seizures because there can be excitability, muscle begins to have spasms, cramps, brain becomes excited, okay, and then this can lead to seizures. So seizure precautions, what do you do? If a patient is having seizures, you don't put anything in the patient's mouth, okay? At first, they used to tell us that we put something to prevent biting the tongue. No, these days, they say that those things are archaic. So you don't put anything in the patient's mouth. You put the patient in a sidelining position to prevent aspiration, okay, to prevent aspiration. Then you make sure that there is no harmful object around. So you clear the environment to ensure that there are no harmful objects around. Okay. You raise the side rails. Okay. You raise the side rails to prevent patients from falling. Now you document. You document the time the seizure started and the time it's ended. It ended. Okay. You document the time the seizure started and the time it's ended. Then you document the part of the body that was involved in the seizure. Okay, you document the part of the body that was involved in the seizure. Let's take it. Okay, you document the part of the body that was involved in the seizure. So these are many more that when it comes to seizure precaution. Then you monitor for cardiac arrhythmias, of course. If there is no calcium, again, let's not forget, enough calcium in the blood, that's what stabilize the muscles. So if there are no calcium, what is it going to do? There's going to be muscle excitability. So even that will occur to the heart muscles. So the heart muscles can now begin to excite. And that one can begin to have arrhythmias. Okay. So you monitor for what? Cardiac arrhythmias. We start cardiac, or let me say cardiac monitoring by putting the patient on the cardiac monitor. Right. So these are some of complications of what? Hypoparathyroidism, right? There are seizures. Okay, I said it just now. They are tetany because of muscle heart stability. There's heart failure. I explain it right now. Okay, if there is muscle stability can occur to the heart muscles, can contribute to arrhythmias and heart failure. Okay, then osteosclerosis can get kidney damage, kidney impairment. Okay, can get kidney damage, and then what do you call it? Cataract. Okay. Now, how does low calcium contribute to cataract? How does low calcium contribute to cataract? Okay. How does low calcium contribute to cataract? Any help? Or let me just say it. Time is almost up. Okay, so cataract, that's
The
what.
lens,
Very good. It damages the
the
lens.
lens becomes opaque.
Very good. Very good. Oh, I thought we were continuing.
Yeah, the lens becomes opaque, and but I don't know the mechanism.
Okay. So low calcium levels damages the lens membrane. Okay. And then it alters the calcium concentration around the lens. That is how it contributes to cataract. Okay. So
Sir,
that is,
can you please repeat that
Can you
again?
please come again?
oh, I said that low levels of calcium damages the lens around the membranes of the eye. Okay, the lens membrane. And then it also alters the concentration of calcium around the lens. Okay. Uh, Okay, so when this even occurs, transport of calcium, calcium ions, around the eyes, it's been affected. Okay, uh, so when this occurs, water begins to build up in the eyes. Okay. All right, so low calcium levels, right, decreases or damages the lens around the membrane and decreases the concentration or alters the concentration of calcium around the eyes. Okay. This will prevent or impair the lens membrane, the ability to transport ions. Okay. And then also it causes water and sodium to be built up in the lens, and this can lead to what? Cataract. All right. So that is that for that is that for hyperparathyroidism, hypoparathyroidism, hyperparathyroidism, and then hypoparathyroidism. Please, any question? Any question? Or if you don't have questions, may I have some questions on my next slide? I can go through them before we end that. But please, any question so far? Any question or any, even if what I said there's something wrong, you can correct me, please. Question, contribution, addition, subtraction. Yes, who is open?
I have a question about what you just said. I think I'm quite confused about the low levels of calcium affecting the causing cataracts.
Okay. So I should go over.
I'll be very glad. Thank you.
Okay, so I said that low calcium levels damages the lens membrane. Okay, it damages the lens around the eyes. Okay, when it damages the lens around the eye, ideally, the lens also help transport ions around the eyes. Okay, so when these membranes are being damaged, and the lens cannot transport the ions very well, Okay, but then it therefore contributes to rather, or it leads to rather accumulation of water and sodium to be built up in the lungs. Sorry, in the lens rather. Okay. Or even to be another explanation is that when the amount of calcium levels, okay, around your lens, the eye lens, falls down, okay, falls down, it makes the membranes around the lens, or the membranes in the lens, very, very permeable to changes. Okay, so it begins to be changing of opacity. It becomes very, very opaque, and then all these prevent the transport of light, and then how the eye begins to eye can function properly, leading towards cataract. Okay, all right, so that is it.
Thank you.
You're welcome. All right, so there's some questioning on my slide. All right, so let's test our knowledge on hyper and hypoparathyroidism. Okay, a patient hospitalized with hypoparathyroidism is about to order lunch. Okay, which food selection is best for this patient based on their dietary needs at this time? A patient hospitalized with hypoparathyroidism is about to order lunch. Which food selection is best for this patient based on their dietary needs at this time? So the options are there. What do you go for? So hypoparathyroidism, the patient must eat what? High calcium diet, yes. High vitamin D rich diet, or vitamin D rich diet, low phosphorus diet, high magnesium diet. So let's pick them.
We'll see do.
B. Broccoli salad, cottage cheese.
Do we have fried chicken anywhere?
And peaches. B.
B, okay.
B. Yeah.
B will do.
B will do.
Broccoli has a high level calcium.
Okay. All right, so let's pick B and C. Let's pick B and C. Okay, if you are right, let's pick B and C if you are right. All right, so the answer is B. So remember, green leafy vegetables and cheese are high in calcium. Okay, green leafy vegetables like contomere, broccoli are high, and cheese are high in calcium. All the other options are high in either protein, carbs, or fiber, carbohydrate or fiber. Okay. All right, next question.
Mosaki, they don't know contomere.
Contomere. Oh, everybody knows contomere. All right, let's.
I mean, Enclaves doesn't know contomere.
Yes, of course, of course.
So we beg.
All right. That's fine. Okay, all right, that's fine. So the next question: a patient is 6 hours post-op from thyroid surgery. So that is thyroidectomy. Okay, a patient is 6 hours post-op thyroid surgery. The patient calcium level is 5, and phosphate level is 4.2. What physical symptoms and signs would, please take note of, what physical signs would not present with these findings? So the options are there. Would not. Okay, focus is on would not. Here it's quiet. Oh, any help? Oh, the question is confusing us.
A, I'll choose A, B, and F.
You choose A.
B and F.
A, B, and
A, B, F. Okay, A, B, F.
I'll choose A, B, E. A, B, E.
Are you sure? A, B, E. Absent trouser sign. Okay.
Yeah. Absent. Sorry. Yeah. A, B, E, F.
A, B, E, F. Okay, A, B, E, F. All
I
right.
also choose
A,
B.
B, E.
Are you sure?
I'll take A, B, E, F.
Yes. We have bronchospasm. So are you picking that? Bronchospasms.
Yes.
EF.
No.
BF.
No. No bronchospasm. Says
BF.
no.
The
Yeah.
answer is BEF.
Yay.
You don't choose
Hey.
bronchospasm because when the calcium levels are low, there will be spasms. But the question is, would not. Here, the calcium level is low, it's 5. So you don't choose bronchospasm because bronchospasm rather occur when the calcium levels are low. The question is asking which of them will not present when the calcium levels are low. Okay. All right. So it's B, E, and F. Okay. So in this scenario, the patient is at risk for hypoparathyroidism, especially considering the lab levels. Okay. The normal calcium level is 8.9 to 10.10. Please let's take to 8.6 to 10.2. Okay. And phosphate level 2.5 to 4.5. Okay. In hypoparathyroidism, hypocalcemia and hyperphosphatemia is present, in which is the case here. Constipation, absent Trausier sign, and hypertension are not seen in hypoparathyroidism. Okay, please, did we get it very well? Hello.
Yes.
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 So always let's pay attention to the question very well. Okay. I always advise that anytime we are reading a question, we should always pay attention to the details in the question. Every question is important. Don't rush. Okay. Don't just be quick. Some people were not picking the E because they saw Trojan sign. They didn't pay attention to the absent. Okay. So please always don't be too quick in answering the question. Pay attention to every detail or in the question. Okay, read every word. Every word is important in the question. Okay. All right, so let's see the next question. A physician orders calcium gluconate IV as a treatment for a patient with what? Hypoparathyroidism. The patient's calcium level is 5. Which of the following finding causes you to question this order? Okay, good. Which of the following finding causes you to question the calcium gluconate? Okay, that is how the question is trying to ask. Which of the following finding causes you to question the calcium gluconate? A, the patient is taking digoxin. B, the patient complains of muscle cramping and numbness in the face. C, the patient is taking aluminum carbonate. D, the patient's phosphate level is 7.
I can hear you.
Hello? Hello? Is it A? Yeah, I think this one we are all quiet too. Any answer, please?
Hi, hello.
Yeah,
C.
hello. C.
I'll take C.
C. The patient is taking aluminum. Why? Aluminum carbonate. Why?
I don't really know, but I know that it's counter threat.
Or you
I
just
think it neutralizes the calcium. I've read it somewhere. It neutralizes the calcium. Aluminum carbonate neutralizes calcium carbonate, gluconate or something.
all right, let's see. Let's see if we are right. C, right? So the answer is A. Madam. All right, so let's see the rationale. Okay, calcium gluconate can increase digoxin toxicity. Please let's take note. Okay, anytime a patient is taking digoxin and then you add calcium, the calcium can rather cause digoxin or can increase digoxin toxicity. Therefore, as the nurse, you should clarify the order with the physician and make sure the physician is aware the patient is on digoxin. Okay, so the answer is digoxin. Okay, all right. Let's take notes, please. All right, the next question.
Yeah.
Yes.
And low this one hypokalemia also increases the judgment of it.
Yes. So these two electrolytes.
Oh, okay.
Yes, these two electrolytes. Yeah.
But Saki, can you
Yeah.
display the previous question again?
It's here.
Okay. Thank you.
All right. Okay. All right, the next question is here. You are providing discharge teaching. Okay. You are providing discharge teaching to a patient who is prescribed calcium supplements with vitamin D for treatment of hypoparathyroidism. Which of the following statements by the patient warrant you to re-educate the patient on how they should take this medication? So we are looking for what? A negative statement. Very good. A, I'll also make sure I eat food rich in calcium, such as dairy, green leafy vegetables while I'm taking this medication. Good. A side effect of this medication is constipation, therefore I should drink plenty of fluid. C, I will take my calcium supplements in the morning when I take my Centroid. I'm sure we all know what Centroid is. Levothyroxine, okay? Another name for levothyroxine is Centroid. D, all the statements above are correctly stated by the patient. This one, we shouldn't waste time.
Is D.
Are you sure?
Yeah.
Why? Why D?
What is the question? Oh, yeah.
Should you take levothyroxine on an empty stomach or you take it with something?
Oh, you take it on empty stomach.
Stomach in the morning, baby. You shouldn't take away any other
Thyroxine
drug.
is taken on empty stomach early in the
I
morning.
see.
Okay, so answer is C. Don't be tricked though, please. Don't be tricked on the ankle. So okay, please always open your eyes. Okay. Oh, why is my mouse? Please always open your eyes. Okay. Always open your eyes. You see how they frame the option C. I will take my calcium in the morning when I take my Centroid. So you might think, oh, okay, we take Centroid in the morning, so that one is fine. Okay. But always Centroid is taken on an empty stomach. Okay, so the answer is C. So calcium supplements should not be taken at the same time as iron or thyroid hormone Centroid because it affects absorption. Therefore, this medication should be taken at separate times. Okay, so the answer was C.
Please come again with the explanation you gave before this one. That Synthroid shouldn't be taken. So we know the level shouldn't be taken, like should be taken on empty stomach. So the
Yes.
calcium too shouldn't be taken on an empty stomach.
Oh, well, when it comes to calcium, you can take it, with food, okay? You can take calcium supplements with food. They brought this to confuse you with a Centroid. They actually brought a Centroid to confuse you, okay? They actually brought the Centroid to confuse you. The Centroid was there to confuse you with the calcium supplement, okay? Yes. All right. Maybe this will be our
So,
last
but
question.
like, when should calcium be taken?
I think I said it. Okay. So
But like,
yes, yes. I said that for calcium.
When should calcium, any other medication, where you have to intersperse them?
I said that calcium should be taken
So
with food.
ideally, when should you take calcium?
Should be taken with food. Even for better calcium absorption, for better calcium absorption, you have to add it once you're about to eat. For better calcium absorption, okay. You should always add it when you're about to eat. Okay. You should be taken with meal or you should take it with food. Please, are you okay? So let's say when it's time for your lunch, then you take your calcium levels, okay, then you can eat. Or maybe you eat, then you take it after. But always it should be taken with food. That's for to help with absorption. Okay. All right. All right. All right. So let's look at I'm sure this will be our last question. Okay. A patient is prescribed alendronate. I think this is a question I asked. The patient is prescribed alendronate. The patient is about to be discharged, and you observe the patient taking the medication. Which of the following findings requires you to re-educate the patient on how to take this medication? So, negative symptom. What are you picking?
A.
The patient taking the medication on empty stomach.
C. Or it's C. At for 10 minutes.
Okay. Okay. The patient.
Yes.
Okay. So the answer is C. Okay. So alendronate should be taken on an empty stomach. So this one too should be taken on an empty stomach. Alendronate. with a full glass of water with no other medications for at least 30 minutes. So you don't take them in combination with antacids or vitamins or usually any other medication for 30 minutes, okay? And the patient should sit down for 30 minutes after taking it to prevent esophagitis. I think so alendronate can cause serious throat and stomach ulcers. And taking it with full glass of water and sitting up afterwards helps prevent this, okay? Helps prevent this. So please, let's kindly take note of that one too as well. Okay, let's kindly take note of that one too as well. Then we are done. Okay, so that brings us to the end of hypothyroidism, and then the end of today's class. Next time we continue with pheochromocytoma. Okay. Yes, please. We are done. Any question, contribution, addition, subtraction as we close? Did we enjoy today's class?
Yeah, very.
Yeah.
Okay.
Yes, thank you.
I'm sure we
Thank
are
you.
okay. I'm sure we are not closing with confusions. We are not closing the class with confusions, right? We've
Not
got
really.
we are getting
Not at all.
okay, all right. So on Friday, when we meet, we'll continue with pheochromocytoma. Okay, we'll continue with pheochromocytoma. All right, so I'll always close with an encouragement. So let me encourage you to keep on doing the good work that you are doing. NCLEX is not easy, okay? Studying for NCLEX is not easy at all. Being by the books, the sleepless nights, it's not easy at all. But then it is worth it, okay, when you have passed successfully. Okay, so please, let's continue to do the good work. Let's be on our dashboard. Let's submit our assignment to our coaches, okay? And then if there's any misunderstanding, kindly reach out to your coach, okay, for the needed support, right? When you have a cube, if you have a cube and keep on reviewing the rationales, doing the cube and reviewing the rationales, and then begin to instill confidence in yourself, okay? Know that the NCLEX is a must do, or you are going to pass the NCLEX, okay? Please, if you are here, you are a second test taker, don't worry, relax. The goal is to get the license and become a US RN. The goal is not to dwell on the past. Forget about the past, it is gone. You focus on the future, okay? Put yourself together, encourage yourself, and know that the second attempt, you are going to make it, okay? So we are closing with this encouragement. Let's keep on doing the good work. And then I'm sure we are all going to get our license, and then we are going to practice safely in either US or Canada by the grace of God. Okay. All right. So we end our class here. See you on Friday.